Yes, sir. Shahana Bhavatu, Shahana Bhunatu, Shaha Virjam Karbhavahu, Tejasvina Vadhyutamastu, Madhidhishavah. Om Shanti Shanti Shanti. Thank you, sir.
Thank you, Vanusri. So, what will be discussed today? That is a practicum, right?
Yes, sir.
So, we have completed the theory papers. So today we will start the practicum. Okay. So please you follow all the discussions that will be held here. So I'm requesting Anusri, please start.
Yes, sir. First, Rose will start.
I'm starting.
Okay, Rose, please you start it.
Okay.
I'm arranging you the.
Okay.
Okay. So now it you can start.
Is it visible, sir?
Yes.
Okay. So as we know, we have completed our theory papers. We are moving on to the practicals, and the first practical is clinical psychometrics. So about clinical psychometrics, today we are going to discuss about the tool construction, how it is like in the clinical. So regarding the clinical tool construction, when it comes to psychometry, it is mainly focused in test construction, treatment, then prevention of emotional and behavioral disorders. And also when the researcher frame instruments, he should pay attention to definition of diseases for diagnosis and symptom severity as well, because it is all related to the psychological constructs. We have seen what is psychological construct before, and can anyone mention it? What is a psychological construct? Hello? Anyone? Hello, please respond. Am I audible?
Yes, yes, you are audible.
Okay. So, so if you are not responding, then I'll have to say it. So psychological construct, it includes mainly the theories. It is systematic, and it includes concepts. It is mainly about operationally defining. So when it comes to clinical, we are going to see some of the examples with regards to clinical tool construction. So we'll see examples. Before that, we have to see what is clinical psychometrics and what is the role of clinical psychometrics in tool construction. So about clinical psychometrics, the definition will be, it can be defined as a discipline that deals with definition and measurement of clinical psychological constructs. So it mainly focuses on the theory and measurement and the construction validation of psychological measures and their application in the assessment of individual differences. So about clinical psychometrics, when it comes to the application part, in what all things they are applied. It is mainly applied in classification of psychological disorders, how the disorders can be classified. Then for the purpose of prognosis, then only we'll get idea about how the disorders are going to be, what is the improvement of the particular disorder. Then it is also used in the therapeutic intervention, and it is also very much important for the clinical psychological tool, because the test construction is very much important, because then only we'll get an idea about how the diseases and diagnosis, symptom severity, etc. are associated. So today we are going to see some of the examples. We are showing these examples because you should need an idea how this is like, how clinical tool construction is like. So we are going to explain how it is with respect to the item construction, how the tools are constructed, what is its psychometric properties, and scoring part, interpretation. So we are only showing some of the examples to you. So first one will be BDI, next is Hdrs, then Hamilton anxiety, then it is PANS, which is related to schizophrenia. About BDI, we are covering it in a very short time. So it will firstly move on. You please follow. So about BDI, it is a self-rated scale. So it mainly evaluates symptoms of depression. And it is mainly focused on mood, pessimism, sense of failure, self-dissatisfaction, guilt, punishment, self-dislike, self-accusation, suicidal ideas, crying, irritability, social withdrawal, indecisiveness, body image change, work difficulty, insomnia, fatigability, loss of appetite, weight loss, somatic preoccupation, and loss of libido. So this is the main definition comes here. We are operationally defining it. Then we know the developer, it is Aaron T. Beck, and it was first introduced in 1961. Then it was revised several times. And when we look into the BDI2, there was first was BDI1, then it was revised and BDI2 was released. So in BDI2, there are two intercorrelated factors, that is somatic affective and cognitive dimension. So these are the two dimensions, and it contains 21 questions, and each item consists of 4-point scale. So it is basically a 4-point scale, which is ranging from 0 to 3. And about BDI, the particular thing is that items 16 and 18, it consists of 7 items. And this indicates the increase or decrease in both sleep patterns and appetite. And about the method, it is a paper pencil self-report, which can be used in group or individual. Then we know it really need a minimal training for professionals to administer. And the main area which we give importance is the self-harm or feelings of helplessness, such as suicidal ideation, which is the item 9, and pessimism or hopelessness, that is item 2. So we are mainly giving importance to this, that is suicidal ideation, self-harm, or feelings of helplessness. Then we have given the time here, how much time is needed for self-administration and also for oral administration. Is it clear? Hello, is it clear?
Yes, ma'am, it is clear.
Okay. So for your understanding, we have given the items in the BDI. We'll upload this PPT in the Google Classroom, so you can refer. And when moving on to the item construction of BDI, it was mainly developed in a similar manner to MMPI, that is Minnesota Multiphasic Personality Inventory. So mainly it is about observations and symptoms among depressed patients, where it is contrasted. That means to among non-depressed patients in order to obtain differentiation. That means a differentiation of depressed group from the rest of the psychiatric patients. And there are cutoff scores for BDI. And in the construction of BDI2, it is mainly adopted with a non-theoretical strategy. So in the case of concurrent validity between scales, we have seen that it states that there is it mainly suggests that there is a need for a theoretical model to Euclidate the relationship. And content validity of BDI appears to be adequate. But when it comes to the BDI1, the content validity is narrower when with regards to BDI2. Then BDI1 is mainly reflected of 6 of the 9 criteria for DSM-based depression. But in the case of BDI2, it is presented an improved performance on specificity to indicate DSM-based depression. And the score range is from 0 to 63. That means total score of 0 to 13 considered minimal range, 14 to 19 is considered mild, 20 to 28 is considered moderate depression, while 20 to 63 is considered to be severe. So this is how the scoring pattern comes, and this is the interpretation of the BDI. And you can see score higher than 40 is extreme depression. And something to be noted in the case of method of scoring is that item 16, that is a sleep pattern changes, and item 18, appetite changes, contain 7-point ratings to note increase or decrease in the behavior. Then it comes to the clinician. It is mainly important that unlike the MMPI and other self-report instrument, a BDI cannot, it do not have any safeguards. That means people can lie, fake. So it do not safeguard against these things. So clinicians are mainly warned against this drawback. This is actually a drawback. So when BDI assess depressive thoughts and symptoms, faking or defensiveness are threats to the validity of the test. Then one another issue is that trait debate in assessment, which means we know that we cannot take it in a long-term manner. That means sometimes the depression can be situational when the person, some close relative or a family member, if the person loses such a close family member, she or he might be experiencing a situational depression. So we cannot take it as in a long-term manner. BDI is associated with anxiety, but it doesn't mean we can always take it into account. Then norms are available for BDI. Norms are very important. And in the case of BDI-2, it is scored by hand or by using a software program such as QLocal. So the scores are mainly recorded by the clinician and the diagnosis is done. And the psychometric information is that it mainly reports high internal consistency, reliability. Then it also have acceptable reliability and validity. Then it makes this test is widely accepted actually because it is mainly used in clinics and hospitals, and it offers a reliable and valid index. So up to this, is it clear?
Yeah.
Okay. So this is another example of Hamilton Depression Rating Scale. Some of you may be familiar with this, Hdrs. So this is mainly used to measure the severity of symptoms of depression. And for many years, it is considered as gold standard. And it was Max Hamilton who developed Hamilton Depression Rating Scale. And these are the items. That means the items are based on these: depressed mood, feelings of guilt, suicide, initial insomnia. You can see more here: delayed insomnia, work and interest, retardation, agitation, then gastrointestinal somatic problems. So these are the items which is dependent. Then this is an example of the item from Hdrs. You can see it here. Don't worry, we'll give this in the Google Classroom so you can refer. Then validity and reliability of Hdrs is good. It is the main limitation of Hdrs is that it does not take into consideration that atypical symptoms of depression. That means hypersomnia, sleeping a lot, excessive sleeping, that is called hypersomnia. Then hyperphagia, which means eating, excessive eating. So that is not assessed in Hdrs. That is a main limitation. Then when it comes to scoring, there are a lot of versions for Hdrs, and method of scoring varies by version. So for Hdrs 17, we are taking Hdrs 17 into account here. So the score of 0 to 7 is generally accepted to be in normal range or in clinical remission. 20 or higher indicating at least moderate severity. So this is the scoring, and interpretation is given here. That is maximum score being 52 on the 17-point scale. Then about BDI versus HDRS. That means we are comparing it here. BDI and HDRS is compared. So both Aaron T. Beck and Max Hamilton created the assessment tool to determine severity of symptoms of depression. But when it comes to these two scales, Beck depression inventory is considered more good because BDI2 can be administered with ease and it does not require any interviewing process. And also in the case of BDI2, the stronger internal consistency, that is alpha coefficient of 0.95 is for BDI2, but in the case of HDRS, the internal coefficient is 0.79 and 0.81. So BDI is more generally considered more strong. And also in the BDI2, the severity of symptoms for depression is for last 2 weeks. But in the case of Hamilton, it does not state any such strict guidelines. So it is this test BDI is well defined. And you can see Hamilton HDS, it was developed to evaluate the performance of the first generation of antidepressants. But in the case of Beck, it was developed to determine nature of the severity of symptoms of depression without the use of medication. That is to be noted. Then is it clear up to here? Hello?
Okay, one point I like to add,
Okay.
that is in case of the HDRS, the rating will be done by the clinician. Okay, not by the self, but in case of the BDI, you can apply the self rating also.
Okay. So can I continue? Is it clear?
Yes, ma'am, it is clear.
Yeah.
So this is another example, Hamilton Anxiety Rating Scale, HADS. So a Hamilton Anxiety Rating Scale is mainly used when it comes to generalized anxiety disorder. It is a very strongly predominating one. So in anxiety disorders, dominant symptoms will be like feelings of nervousness, trembling, muscular tension, sweating, lightheadedness, palpitations will be there, dizziness, epigastric discomfort will be there. You'll be feeling dry very much. So these are the common symptoms of generalized anxiety disorder. It was again developed by M. Hamilton and it is widely used interview scale measures. Then it is mainly formed on the basis of 14 parameters. So Hamilton anxiety is one of the first rating scales developed to measure severity of anxiety symptoms, and it is widely used in clinical and research settings. And when it comes to the items, the scale consists of 14 items, and it is based upon psychic anxiety, that means mental agitation and psychological distress, and also somatic anxiety, that is physical complaints related to anxiety. Scoring is 0 to 4, which is total score range is from 0 to 56. So below 17 indicate mild severity, 25 to 30 is moderate to severe. And about the reliability, it is 0.77 to 0.92 validity. The clinical assessment, when it is compared to the COVI anxiety scale, it has good validity. Then one of the major limitation of Hamilton anxiety is that it sometimes do not discriminate between anxiolytic and antidepressant effects and somatic anxiety versus somatic side effects. So the scale does not discriminate between these things. And one of the main criticism against Hamilton anxiety scale is that it does not provide any standardized probe questions.
Ma'am, what does anxiolytic means?
That means when we use some of the antidepressants, the effects of it.
These are medications for anxiety, anxiolytic.
Yeah, mainly we refer to the medications. Is it clear?
Yeah, it is clear.
Then can I continue with this one?
Yes.
Yeah, So Yale-Brown Obsessive Compulsive Scale is mainly known as white box. It is mainly, it is very famous actually, used in clinics, and it is mainly related to the obsessive compulsive disorder, and it is used to rate the severity of obsessive compulsive disorder, that is OCD symptoms. And the essential feature of OCD is that we will have recurrent obsessional thoughts or compulsive acts. That means compulsive acts or rituals that are stereotype behaviors. So it is like the rituals will be repeated again and again. So the obsessions are mainly defined by 1 and 2. One is the recurrent and persistent thoughts, urges, impulses that are experienced at some time. Then second one will be individual attempts to ignore or suppress such thoughts, urges, images, then to neutralize them with other thought or action. Like in the case of neutralizing, will be performing the compulsion. And the items there are mainly 10 items in the scale. So mainly the items depend upon the patient report, but in the case of final rating, it is based upon the clinician's judgment, that is the clinical judgment of the interviewer. Then the rating scale is intended for a semi-structured interview. Here we are not depending upon the scale only. We are doing a semi-structured interview. We are asking questions to the client. We are trying to understand what the client is going through. We are trying to get what is his condition, and what is the way of his thoughts, how is it going. So semi-structured interview is important in Y box. And questions 1 to 5 are obsessive thoughts. Then obsessions are unwanted ideas, images, or impulses, as I have mentioned before. Then other questions are about compulsive behaviors. Then you know what are compulsions. Compulsions are urges that people have to do with someone to lessen feelings of anxiety. So what they have to do is they have to reduce their feelings of anxiety. So they try to repeat this. They try to perform the rituals. And about the validity and reliability, scale is validated by Goodman et al. That means there are a number of people. Then Y box also have high internal consistency and inter-rater reliability. About the scoring part, it is scored on a 4-point scale from 0 to 4. That is no symptoms to extreme symptoms. And the score range from 0 to 40, with high scores indicating greater severity of OCD symptoms. And it is classified like this: under 7 are likely to be subclinical, 18 to 15 have mild case, and the extreme score comes like 32 to 40 are like to have extreme case of OCD. Now we can say up to here, is it clear?
Yes, it is clear.
Okay, we have only one more example. These examples are very much needed, then only you can understand how the clinical tool construction is. So about PANS, it is the positive and negative syndrome scale, which is associated to schizophrenia. Schizophrenia disorders are mainly characterized by fundamental and characteristic distortions of thinking and perception. And there will be inappropriate blunted affect too. So there are mainly 2 kinds of symptoms that occur, that is positive symptoms and negative symptoms. In the case of positive symptoms, it includes delusions, hallucinations, experiences of passivity and control, then disorganized behavior and thinking. When it comes to negative symptoms, there it covers reduction or restriction in affect, speech, motivation, and social interactions. So PANS is basically a medical scale. It is used for measuring symptom severity of patients with schizophrenia. And you can see how the items go. In the positive scale, there are 7 items. In the negative scale, there are 7 items. And this is the classification, how the items are based on delusion, conceptual disorganization, hallucination. So you can read this. This is how the items are related. And this is the general psychopathology scale in the PANS, and it contains 16 items. So this is about the general psychopathology scale. And about reliability and validity, the PAN show good iterative reliability and test retest reliability, that is 0.92 and 0.75. Validity shows good sensitivity and specificity. And norms are available for the test. When we search some of the scales, the norms are not available. We cannot see it as the scales are to be paid, then only it will be, we can get access to it. But in the case of PANs, the norms are available. That's why we are showing the norms. So you can see how the bipolar index, general psychopathology. So when the score is 0 to 7, it is absent. Then 8 to 14 minimal, 15 to 21 mild, 20 to 28 moderate, 29 to 35 moderate severe. So this is how the norms come. And about the scoring part, there are 7 points, which is with respect to the increasing levels of psychopathology, like 1 be absent, 2 minimal, 3 mild, 4 moderate, 5 moderate severe, 6 severe, 7 extreme. And in the case of scoring, there are some instructions. That is, of the 30 items included in PANS, 7 constitute positive, 7 negative, then remaining 16 is general psychopathology scales. That is what we have shown before. And here is the references. So you'll be getting this PPT in the Google Classroom.
Ma'am, I have a question here.
Yeah.
How should be the score? How much the score needs to be have a good reliability and validity? What is the valid score to consider as a valid, reliable, and it is valid?
Yeah, actually 0.6 is accepted and 0.8 is very it is considered good. 0.9 will be very good actually. It is considered as a very good scale. 0.9 is considered very good scale.
It is both for validity and reliability.
It is a correlation coefficient. It's a correlation coefficient, na? So the range is from 0 -1 to +1. So more it is above 0.50, that is good. And 0.70 to 0.8, 0.9 is very good. And that is true for both reliability and validity.
Okay, yeah, okay, thank you.
Okay, so any more questions? Can I stop? Hello? Is it clear? Hello?
Yes, it is clear, ma'am.
Okay. So next we have an exercise to complete. This is the practical. We are going to administer one scale to you, that is General Health Questionnaire, GHQ 12. Have you heard of that?
Which scale you are talking about?
GHQ, General Health Questionnaire 12.
Yeah. I heard about it.
Okay. So we have given you a message in the group and there are the items of General Health Questionnaire. So you can see the items there. Then you have to give your responses, like it will be scored from, it is mainly 4-point scale. That means the scoring will be 0, 1, 2, 3. That means from least, less, often, very often. Is it clear? Is the scoring clear? Like you have to do it right now. The items are in the WhatsApp. We have messaged you the items and the responses are to be like 0, 1, 2, 3. That is 4-point scale. And it will be like least, less, often, very often. So you have to rate accordingly. You have to give your answers accordingly. Then after giving answers, we have to interpret your scores.
Those please you add another thing, that is last few weeks.
Yes, sir. Yes, sir. So the scale is based upon mainly GHQ is used to understand mental disorders. So it is based upon what is your condition of past few weeks. It is related to that. We are assessing the scale based on that. So just try to complete it so we can interpret the scores. We'll say how to score. Just give your answers first.
Yes, give your answers, then you have to interpret it.
The items are in the group. You can see that.
Ma'am, can you mention about the 4-point scale meanings, like 0 is for 0,
Yeah.
2, 3?
0 is for least, 1 is for less, 2 often, 3 very often. I have given you how to give your responses in the
Okay,
group.
okay, ma'am. So I have to give responses on these 12 items.
Yeah.
Yes, yes.
Only this thing.
Yeah.
Okay.
Just copy the items and then you can write your answer in just below the item.
So it will take a lot of time if I write each and every item.
Just
Okay.
copy
Just
it,
copy
just
it.
copy the item and then put your rating beside each item. All of you can submit it in the WhatsApp group.
Ma'am, I have done. about responses. And what is this SDADLC?
Yeah, that is the scoring part. We'll explain that to you.
Okay. And now should I post it on
Yeah.
WhatsApp? Okay.
Yeah.
Yes.
Ma'am, I have a question.
Yes, Ayushi.
So, ma'am, when we are collecting data from people online or offline, there's a lot of biasness when they give the answers. So, how can we overcome that?
Mainly when we collect on data from online, yeah, some of them will be not interested to do it. Some of the questions they seem it boring. So that is actually a limitation. Sir, can you contribute something how to avoid it? Sir, are you there?
Yeah, for the same, this problem is very nice problem. Thank you, Ayushi. It's a very good question. Two things are important. Number one, good rapport. If you can establish good rapport, then you will be able to get the proper answer, number one. And number two, you have to collect the data in such a manner so that the number of items will be less. Okay, and you will instruct properly so that there will be no difficulty for understanding and for responding on the basis of your instruction. And number three, that is, item should be very small. It should have one principal clause. There will be no subordinate clause. So one finite verb will be there. Then I think you will get the positive answer. But if your item has some subordinate clause, there will be a lot of the problems for understanding. Okay, and once upon a time, that is, if the respondent has this mindset, that is, oh, I cannot understand, then your total data will be spoiled. Particularly for research purpose, my suggestion is to increase the sample size and you convince the people properly. Yeah, and you have to convince the people or the respondents properly so that you will get the proper data. That is a good data. If you do not get the good data, then there will be the problem in estimating the reliability, validity, etc. Yes, now tell me.
Sir, I wanted to ask that you mentioned that the questionnaire needs to be very short and precise. So, how do we can collaborate 2-3 questionnaires in one questionnaire? I really want to learn that. So, can you just tell me something about it?
So if your questionnaire is unidimensional, then it will be very easy. But if your questionnaire is multidimensional, then it becomes difficult. Okay. So that is my suggestion.
You finish?
Yes,
Okay. So then we can score the assessment. Sir, can we start?
Yeah, you can start now. If
So,
they have completed.
okay. Everyone is completed, right?
yes.
Okay. So please mark SD near to the items 1, 3, 4, 7, 8, 12. It is given in the WhatsApp group SD. Please mark SD near to the items 1, 3, 4, 7, 8, 12.
Done, ma'am.
Okay. Now please mark AD near to the items 2, 5, 6, 9. AD near to the items 2, 5, 6, 9.
Okay, done.
Now mark LC near to the items 10 and 11.
Okay, done.
Okay. So, something to be noted here is the items 2, 5, 6, 9 are reverse code. They are the reversed items. So it is given in the group. Reversed items are 2, 5, 6, and 9. So in that case, for the reversed items, you have to do the reverse scoring. That means 3, 2, 1, 0. Is it clear?
Yes, done.
Okay. Now you can add your scores. You should consider the reverse scoring also. Okay. Then add this scores accordingly. Like for SD, what is your score? For AD, what is your score? For LC, what is your score? So you will have 3 parts, 3 scores. For each of them, for each of you, you will have 3. Please consider the reverse scoring as well. Then only you'll get the accurate scores. We will tell you what is ADSD and LC. That is a suspense.
Done, ma'am.
Okay. So, okay, sir, can I individually ask them what are their scores?
No.
Okay.
Don't ask them. Just you tell them if this is the score, then this is the interpretation.
Okay. So, 1 minute. Anushree, can you tell them the interpretation? My net is,
I think norm is not there.
yeah.
Sir, can you contribute the norm?
Yeah, you tell them that if this is the score, then this will.
The norm is not there.
Norm is not with us.
Okay, so what is the score?
Ayushi, please tell what's your scores?
SD 17.
SD 17.
Yes, sir.
And how many items are there?
In SD, we have 6 items.
6 items. Okay, next.
80 is 9.
Which one?
80.
AD is 9.
Yeah.
How many items?
We have 4 items.
And
And
LC?
LC is 2.
What is your total score?
I have not calculated the total. I need to do that. I'm calculating, sir, total.
It is 28, Ayushi. You have given us 17, 9, and 2. That is 28.
Okay, ma'am. Okay. It's 28, sir. Total score.
So how you have calculated?
Taking 3 of them.
No.
I have to individually add every item, right? Or
How
reverse?
many positive and negative items are there now?
Yeah. I was doing it individually. I know he alag dimensions. Yeah, I'm doing, sir.
Please reverse scoring is there.
So please you do the reverse scoring.
22, sir.
Now it is okay. 22. 22. Okay. And what are your the items? We have to check the items because this it indicates very high score. So 22 not expected. Possibly there is some problem in your scoring.
Sir, I have got 21.
No, some scoring problem is there maybe. For example, which are the reverse item? Okay, do you feel reasonably happy considering all the circumstances? Whether you have considered it as a reverse item or non-reverse? Have you felt unhappy and depressed? Is it a reverse item or not? What is your score? Have you felt unhappy and depressed? Ayushi?
Sir, I have done this reverse scoring only for the reverse scoring items.
So what are the items that is reverse?
Items 2, 5, 6, and 9. I have done the reverse scoring in that.
So what is your score? Have you number 2?
Number 2, my score. It is 1.
1.
Yeah, 1.
Okay.
And 5 is also 1.
And number 1?
Number 1 is 3.
Okay, there are 2 approaches are there. One is related to the if your that is a negative items. For example, have your worries made you lose a lot of sleep? If you think that is it is agree, okay, then you will get 1. But have you been able to concentrate well? Then it will be the 0. So the maximum score will be 36. Is it clear? So there are some items that is related to this one. Have your worries made you lose a lot of sleep? If your answer is agree, that means the score will be 1. And have you been able to concentrate well on what you are doing? Then the score will be 0. That means higher the score, there will be more mental health problem.
For item 2, we have reverse scoring. So,
So doesn't it go other way around? When we
No,
have
there
the
is
lower score assigned, would not would that not imply that they have higher
No,
distress?
so that depends upon your scoring. So my point that is, if there is a score greater than 15, that means there is a problem. So it will be the 0, 0, 1, 1.
I'm not able to understand.
For example, have you been able to concentrate well on what you are doing? If it is, you say that is strongly agree, that means it will be 0. But if you say, have your ODs made you lose a loss of sleep? If you say strongly agree, then your score will be 2. 0, 0, 1, 1. So 0 means positive items and 1 means negative items. So higher the score, that is high chance for the mental health problem. Is it clear?
Not clear, sir. I'm not
No,
able to follow.
you do because you have to do your own exercise.
I've completed my scoring, sir, but I'm unable to understand what you are saying.
Okay,
so
what is your score for number 1?
For number 1, it is 2.
Number 1, 2. So
Yes, sir.
what is the rating?
Rating, sir?
Yes.
On the scale, I've rated is 2, sir.
No. What is the rating? How frequently or like that? Most frequently or least frequently?
Okay.
That I do not know now.
That comes to often, sir.
Often, though. Okay, then the score is 0. Next one is the number 2. What is your score? Without reversing. Anindita? Number 2, what is your score?
Sir, I think it was wrongly communicated, I think, sir, because if the whole scale has a scoring rating from 3 to 0, then what you say makes sense, where the reverse scoring alone will have increased
No, if you
scoring.
if you modify the reverse position, then that will be the positive. And if you do not change the reverse position, then it will be the negative. And if it is a negative, then their score will be the 1, 1. And if it is positive, then that will be the 0, 0. So if your score is higher, then there will be the problem in the mental health. If score is less than 15, that is the less, then the score is better.
I guess, sir, what mistake we are doing is we are calculating the raw scores as total, and we have not reversed the items. I reverse scoring.
That's the thing.
That's the problem, I guess, here.
3 approaches are there. One side, that is the 0, 0, 1, 1. Another is 1, 2, 3, 4. Another is just to change the reverse score. That means if have you been able to concentrate well on what you are doing? So if you say, okay, strongly agree, then it will be the reverse score. And have your ODs made you lose a lot of sleep? Then that will be your non-reverse score. So higher the score indicates the mental health problem. Is it clear now?
Sir, it is not clear at all to me. Because sir, I am unable to understand that which item is -1 and which is one is the
So that is
positive
already
one.
discussed, no? I think Rose has already told you. That is what are the items that is reverse and what are the items non-reverse.
No. Only there are 4 items which would be reversed scored. Only 4 items are there, and
No.
rest we can see say that all the other items like sir, 8 items, they are all positive.
Yeah, so few items are there, that is the negative item.
So
So
only
that
the
will be-
reversed score, they are the -1 items.
Yeah, so that means the higher score indicates the mental health problem.
And sir, for this interpretation, we need norms. If we don't have norms, we cannot interpret.
Norm means norm. If you follow the 0011 technique, then the norm is more than 15. If your score, that indicates there is some problem. That is the norm. But if you follow the 1, 2, 3, 4 approach, that is for the research purpose. Usually, the researchers are using GHQ for the research purpose. Another, some researchers, they are using GHQ for the categorization. If you want to follow the categorization, that is whether the individual will be the psychiatric or not, then you can apply, that is the 0011 technique. So all the zeros, that will be the positive and 1 will be the negative. So if you think that is the agree, then you will get the 1. And if you think that is strongly agree, then it will be the 2 for the negative items. For example, this is the negative item. Number 2 is the negative item. Number 5 is negative item. Number 6, negative item.
So, sir, what would be the maximum score for these 12?
36 is the maximum score.
36.
Yeah. So if you give the 1, 1, 1, 1 everywhere, because 12 items are there. So have you felt unhappy and depressed? That is the negative item. So 9 negative item, 10 negative item, 11 negative item. Others is positive item. So I have told you.
And sir, what is the lowest one?
Lowest means?
Lowest score would be 0.
No, the lowest score will be the 0.
Okay. And sir, how we would assess the middle score, moderate one?
No, it is not the moderate one. It is the, if you follow the 0, if you follow the 1, 2, 3, 4 model, then you can think about the moderate one. So that will be 36. But if you follow the 0011 approach, then more than 15, that indicates psychiatric disorder. So now you put your positive items at the first, you write the positive items and you score it, and then you put the negative items and then you score. And after that, you tell me what is your score. Is it clear now? You can follow another approach, that is the 0, 1, 2, 3. That is the Likert score. Another approach is the 0, 0, 1, 1.
Sir, I have a question.
Sure.
Sir, is this 0011 approach, is it used widely or the Likert type is used more?
No, Likert type usually, I also use GHQ12, but that is I have followed the Likert type for my research purpose.
Okay.
In my PhD, I have used GHQ12. Okay, and there I have followed this 1, 2, 3, 4 model. Instead of the 0, 1, 2, 3, I have used the 1, 2, 3, 4 model. But in case of the psychiatric issue, that is a cutoff point, determination of the cutoff point. It is better to follow the 0, 0, 1, 1 model.
Okay.
Then the 15 is the cutoff point. Now you take the data from Anindita and then you can score it.
Just to clarify, sir, so we are taking the lower 2 points as 0 and the higher 2 points as 1 scoring. Am I correct?
Yeah, yeah.
Okay.
That is for the negative items. Positive items will be the 0. I am giving you one reference paper. You can check it. Huh? Oh. Is it clear? Have you done the scoring? Ayushi left. Okay. Rekha Anindita is there. Mona Lisa is also there. Am I audible?
Yes, sir.
So Anindita, is it clear to you?
Yes, sir, somewhat.
Yeah, so you just set aside the negative items and set aside the positive items. Higher the score in the negative items, that means there is some psychiatric disorder. If the score is above 15. Okay, and I have sent one paper to your to the group. You can study it. Then it will be clear. And another interesting point is there we will find that the 3 dimensions are there. So in these 3 dimensions, you can identify where your problem lies.
Sir, we haven't told them what is ADSP and
Okay, so please you tell them.
okay. So AD is anxiety and depression. SD is social dysfunction. LC is loss of confidence. Is it clear? Is it clear?
SD is what?
Yeah.
SD
SD
is what?
social dysfunction.
Social dysfunction.
And LC?
Loss of confidence.
I am requesting you, please you collect data at least from 5 people having some problems in insomnia, having some problem in concentration difficulty, like that. And then you can interpret the data and you can discuss this data. Okay? Is it clear? So, Anushree, please start the prayer.
Sir, may I continue the development of the tool or it will be done on the next day?
Tool development, it is not 9:30.
Yes. Okay.
For that reason, I have told na, that is we have to start early.
Are they available from 7? Please, hello, am I audible?
Yes, ma'am.
Okay, please inform, are you available from 7 for the next day,
7.
7 p.m.?
Ma'am, actually, there is a problem in attending classes further for Friday and Monday, actually.
Okay.
Because I have an interview in some university, the job. So that is why.
It was informed by many one that they have problem from 7. So, sir, I think
Then you can do one thing, you can tell, you can give the information in this classroom, Google Classroom, and assign some question so that they will read your lecture notes and they will answer.
Okay, now I just want to convey you that next step is to learn how to develop a tool that is based on the clinical psychological construct. So the steps are several steps are there, and you have to learn how to do it, how to frame the items, how to do the interview. So there are several steps, and I will upload it. Upload the PPT in the Google Classroom. If you face any problem, you can ask. So it is not, we don't have this time to explain it in the class. So I will upload it, and please go through and study.
I think if Rekha and Anindita can manage the time, then you can continue.
Okay.
Because they are here, so maybe today they are okay.
Okay, may I start?
Yeah, please start.
Is it visible?
Yes, yes.
Okay. So you have learned today some of the example of the clinical psychological tool, and now we will focus on the development of the tool, how to develop the tool for the clinical psychological assessment. So this is the definition. You know, the clinical psychometrics can be defined as a discipline that deals with the definition and measurement of clinical constructs, and it focuses on the theory of measurement, the constructions and validation of psychological measures, and their applications in the assessment of the individual differences. And now our aim is to focus on how a PhD scholar or a researcher can conceptualize the clinical psychological construct. And just for this, we are selecting our PhD thesis, and that was done by Dr. Shivani Santosh under our sir, under the supervision of our sir, Dr. Bedula Roy. And that is based on the cognitive self-efficacy of schizophrenia. Okay. Cognitive self-efficacy of schizophrenia. That is the thing she has done. Can anyone tell me what is cognitive self-efficacy? Do you have idea? Anyone?
Okay. Is it somewhere along the lines of judgments or capabilities of an individual?
It's not about judgment, it is about belief system. That is, you can see here the definition. Cognitive self-efficacy was defined as belief in one's own capability to use cognitive functions effectively to attain certain desired goals. So it is not about the capability of an individual, it is about their belief about their capability. Okay. So this is the belief in one's own capability to use cognitive functions effectively to attain certain desired goals. That is cognitive self-efficacy. And our focus is to find out the cognitive self-efficacy in schizophrenic patients. Okay, it includes 4 domains. The domains are self-regulation, that is belief in one's capability to regulate self for goal setting and its achievement. Inactive mastery experience, that is belief in one's capability to play different roles and responsibilities in spite of illness. Vicarious experience, that is belief in capability to imitate successful persons and to follow them. And controlling physiological and emotional states, that is belief in one's capability to control self-anxiety and physical illness. Okay, so here objective is to conceptualize and develop an instrument to assess cognitive self-efficacy in patients with schizophrenia. Okay, this is the objective. So we will start with the method for developing the tool. There are several steps. Dr. Shivani used semi-structured interview at first to record patient socio-demographic details and clinical variables. So can anyone tell me what is semi-structured interview?
It is when you have specific questions to ask and you don't deviate from the list of questions you've prepared.
I can't hear you. Can you repeat?
It is when you've prepared a set of questions based on your variable and you don't deviate from the set of questions you prepared. You do not give anything spontaneously.
Yes. It is a semi-structured, that means there will be some preset questions and not the preset questions. it's a combination of both structured and unstructured. That is the semi-structured actually. A semi-structured interview is a type of interview in which the interviewer asks only a few predetermined questions, while rest of the questions are not planned in advance. Since semi-structured interview combines both the structured and unstructured interview style, they can offer advantages of both. They allow for the objective comparison of candidates while also providing opportunity to spontaneously explore topics relevant to that particular candidate. Okay, so here are some of the examples of the semi-structured interview that was done by Dr. Santosh. Some of the examples are, do you face any difficulty using your mind while doing any work? What are the main problems you have in continuing any work? What are the main things you want to change in the way your brain works and why? Those are the examples. Okay. After the semi-structured interview had been done, patient's verbatim was recorded and transcribed. So from the verbatim, we have to transcribe the record so that we can get the variables or get the points or components that should be added or should not be added. So patient's verbatim was recorded and transcribed. 9 cognitive difficulties are identified along with ways of dealing with them. So after the semi-structured interview, Dr. Santosh had found 9 cognitive difficulties and along with ways of dealing with them. Okay. Now, what is this transcription of verbatim? That is, an interview transcription is a written record of a completed oral interview. The interview transcription document possesses conversation between 2 or more people. What are the advantages? It captures each detail for the interviewer to review later. Interview transcripts enables others to access the interview. It allows the interviewer to focus on specific area. It provides interview with direct documentation and it saves valuable time. Okay. Now the procedure for interview transcription. What are the procedures? That is, listen to the full recordings, determine how much time will be needed, select the proper tools, write a draft first, use shortcuts, proofread the draft, format the transcript. Okay, these are the procedures for interview transcription. After the transcript versions, it was analyzed by Dr. Santosh and following difficulty areas were obtained. What are the difficulties areas? That is attention and concentration in the patients with schizophrenia, flexibility, working memory, verbal fluency, planning, visuospatial coping, regulation, and learning. These are the 9 cognitive difficulties she has found from the transcript versions. The third stage is the inter-rater agreement. A rating scale was prepared and given to a group of independent psychologists, and they were asked to rate on 5-point scale whether they agreed or not that the above cognitive difficulties would be present in patients with schizophrenia. So she had found 9 cognitive difficulties, and after that she prepared a rating scale and it was given to the raters so that they can rate whether they agreed or not that the 9 cognitive difficulties would be present in the patient with schizophrenia or not. So inter-rater agreement was done, and it is the, what is inter-rater agreement? You know about it when you have learned the reliability. It's the degree of agreement among independent observers who rate, code, or assess the same phenomenon. And Kendall's W was computed to assess overall agreement over the above mentioned dimensions among the 4 raters. agreement of W equal to 0.60 was obtained. So Kendall's W was done to find, so it was written that W ranges from 0 to 1, there is no agreement to complete agreement. And you can see that the W is equal to 0.60. That means above average correlation coefficient is there among the raters about their agreement. Okay. But they agreed that these cognitive difficulties can be present in the patients with schizophrenia. Okay, is it clear? Hello?
Yes, ma'am.
Clear. Okay. Now the fourth stage is item framing. Those with higher mean ranks were coping, verbal fluency, regulation, immediate working memory, attention and concentration and flexibility included for item framing. So after the inter-rater agreement, the cognitive difficulties that were with the higher mean ranks that were included for item framing. So what is item framing? On the basis of those dimensions, fourth stage is item framing, and on the basis of those cognitive difficulties, items were framed. So on the basis of the dimensions, a pool of 40 items are framed. So on the basis of those 9 cognitive difficulties, 40 items were framed. Okay. And the scale items are rated on 5-point scale, that is strongly disagree, disagree, undecided, agree, strongly agree. And it was administered on 15 patients. But it was found patients are getting confused while rating on 5-point scale. Therefore, response pattern was changed to yes, no pattern. Can anyone tell me what is the type of this scale in case of yes, no?
It is nominal.
Yes, this is nominal. Okay, 5 items are dropped due to repetitiveness, and 35 items of cognitive self-efficacy questionnaire was administered to 100 patients diagnosed with schizophrenia by Institute of Psychiatry, Kolkata. Clear till that?
Yes, ma'am.
Yeah, clear.
So Cooder-Richardson reliability will be done. You know why we use Cooder-Richardson? Anyone can tell me why we use Cooder-Richardson reliability when we use it?
If there is a response type 0 and 1.
Yes, no, not that. Actually, when we are trying to measure the internal consistency, we are doing the Cooder-Richardson, Cronbach's alpha, split up. Okay, so you know how to do it. The measurement of the internal consistency, and for this purpose, Cooder-Richardson reliability coefficient was done to measure the internal consistency of the items. Okay. So it was found at first that is 0.87. And then you know the next step is to find out the item total correlation, that is the correlation between the each item and the total score. And that indicates the correlation coefficient, which items are low consistent, which items are highly consistent, that poorly consistent and highly consistent. So after the Cooder-Richardson reliability coefficient had been done, the item total correlation was done, and the items which are poorly consistent that were dropped. And after that, 25 items were found, that is with 0.91 correlation coefficient reliability. Cooder-Richardson of 0.91 was found. Okay. So for measuring the internal consistency, Cooder-Richardson reliability was done, and that was at first 0.87, and after that, she has done the item total correlation, and she found that there are some of the items that are poorly consistent. Then she dropped it, and after that, again, Cooder-Richardson reliability was done, and it was found for the 25 items, it was 0.91. So finally, 25 items were extracted. Okay. Clear till that? Hello?
Yeah, yeah.
Okay. The next step is to do the factor analysis. Do you have any idea about factor analysis?
It helps us narrow down on the various items that seem to measure a single factor in a question.
Yes. It helps to reduce large number of variables into fewer number of factors so that it can be more manageable to us. Suppose I have numerous number of items or questions about a topic. I try to find out certain factors, and I have to put all the variables into this certain factor by grouping the variables into factors based on their correlation. Okay. This is the thing. Just you can you can understand that we have to reduce the large number of variables into fewer number of factors so that it will be more manageable. For that purpose, we are doing the factor analysis. Okay. Is it clear?
Ma'am, I have a question. Can we do factor analysis using R?
Using R?
Yes.
Correlation coefficient?
No, using R Studio.
Okay, R Studio. I think we can do. Sir? Sir, are you here?
Hello, bolo, sorry.
Yes, sir. Can we do factor analysis using R script?
And now it is 10.
No, sir. They were just asking, can we do with R script?
Sure.
Okay. We can do.
It is very easy.
Yes, we can do. Okay. That is the thing. We are doing the factor analysis for extracting factors from the numerous numbers of variables or items. Okay. Dr. Santosh defined cognitive self-efficacy as a multidimensional concept, and she revealed 3 factors from this pool of items. Okay. The factor 1 is the contextual self-regulation. Factor 2 is the efficacy and flexibility, and factor 3 is intra and interpersonal coping. Here is the example of the 3 items just for your understanding. That is, these are the items and those are the factor loadings. For factor 1, that is 0.80, factor 2, that is 0.43, for factor 3, that is 0.10. And it indicates just the variance explained by the variable on that particular factor. Okay. That is, for this particular item, the variance, that is 0.80 unit, can be explained by this variable for this particular factor 1. Okay. Is it clear?
You continue.
Okay. So these are the things. We are just showing the factor loadings. And this is the commonality. Commonality indicates how much of each variance the variable is able to explain. And that can be found out by squaring those. Like 0.80 square plus 0.43 square plus 0.10 square, it will be 0.83. That means how much common variance can be explained by these factors. Okay. For all of these three factors, how much proportion of common variance can be explained by this particular item or variable? That is the commonality.
I'm just curious. Will we be covering factor analysis in detail in the upcoming classes by any chance?
Please ask Sir whether we can. Sir, they are asking for a class that is based on factor analysis.
Factor analysis is not in our course, in this course.
Yes.
Yeah, I understand, sir, but I was just wondering because I want to teach this to my students and I want to get a better understanding of this. So I'm just wondering if that's
Oh, for that reason, I can tell you.
Okay.
For your students, it is not the problem. But for the PhD and other things, definitely. There are many things are involved.
Yes, there are many things to understand.
For postgraduate students,
we have this as a part of our syllabus in the curriculum that we have, sir. So I was just wondering if I could get more information or even a reference book. I think that would be fine as well, so I can teach them better.
here Anderson and Tadam.
Come again, sir?
Here Anderson and Tadam.
Okay, okay, all right, I'll check it out. What is the book name, sir?
Maybe Introduction to Multivariate Statistics, like that, or Handbook of Multivariate Statistics.
All right, sir, I'll check it out.
This is nice. That is your university is interested for multivariate model. Usually people are afraid of using multivariate. So they are
we have a
we are
whole
not
paper
interested.
on research methods and applied statistics. So we go in depth into it. And we also have a separate paper on psychometry as well.
Okay, okay. That is good. That should be. Because here
It's
I find that is
the
people are not using the psychometrics, so they are usually follow the qualitative approach. They are collecting data from 2 or 3 people, and after that they are presenting their dissertation. So this is the style.
This is a newly constructed course.
They are telling that is I have followed the qualitative approach. That's all.
Yeah.
Then what will you do? Nothing.
This particular course structure is available only in our college, sir, because we did it particularly for our college. So it's not a curriculum that's available anywhere else as of now.
Yeah. So that is the important part, no? Because your college is interested in quantitative techniques.
Yes, sir. It was developed by our department, sir.
Yeah. So, and you have the interest for that. That is important.
Yes, sir.
Okay, I'm going to continue.
Sure, you continue.
Okay, so this is the commonality. That is for all of these 3 factors, how much proportion of the variance can be explained by each item. Okay, that is the commonality. How much common variance can be explained by the items. Okay. So 7th stage is the intercorrelation matrix. You know, it is very simple. That is the correlation within the factors. That is with factor 1, factor 2, factor 2, factor 3, factor 1, factor 3, just like this. We have to do the intercorrelation between the factors. And the 8th stage is the test retest reliability. And that is also very common to you. The final questionnaire with 22 items was administered to 30 patients twice within a 2 weeks interval. And test retest reliability for contextual self-regulation is highest, so that is 0.91. For efficacy and flexibility, that is 0.77. And for intra and interpersonal coping, that is 0.67. And lastly, this is the procedure of administering the questionnaire, the final questionnaire that includes 22 items. After doing all of those steps, and then it was administered on the patient with schizophrenia, and after that, the result that is found, that is with respect to contextual self-regulation, 57.33% of respondents reported that they had belief in taking active participation in management of their illness. Only 38% of respondents reported yes response to the item, I believe, I feel sad, when not able to remember the current day and date. And for efficacy and flexibility, 64% of the total respondents reported yes to the item, I believe, I try to remember the location of important places. Only 48% of total respondents reported yes to the item, I believe, if I record, I can do 2 to 3 tasks at a time. For intra and interpersonal coping, 64% of the respondents reported yes to the item, I believe, in spite of my illness, I don't lose hope. 43.33% of total respondents gave yes to believe, I notice, learn how other patients are talking to doctors to express their problems. That is the result that was found after administering the questionnaire. That is the way. Okay. Clear till that?
Yeah.
Okay. I think you can go through this item analysis, factor analysis, and you can understand for this particular purpose, not for research purpose, but for this particular purpose, you can understand this. Okay, I am closing.
So thank you, Anu. Thank you,
Thank
Rose.
you,
Thank you,
sir.
Anindita, Rekha, Monarisha.
Thank
Thank
you,
you all. So Anusri, now start the prayer.
I forward this prayer.
Huh?
I forward this prayer.
Oh God. Okay. So please close your hands
Yes.
for the prayer. Om Purnamada Purnamidam Purnamudachyate Purnasya Purnamadaya Purnameva Vashishyate. Om Shanti Shanti Shanti. Okay, thank you everybody.
Thank you,
So
sir.
may I close now?
Yes.
Thank you, sir.
Okay, good night.
Good night.